Hi guys, so today I'm going to be talking about chronic interstitial restrictive lung diseases. Now, this is basically the content that's going to appear. There are two major diseases that you have to know, and then I'm going to be talking about them. And then there are others that you need to mention, but they're two diseases that they really, really want to know. So, this was basically my exam question, so I can give you some insight about the questions that they will ask you. So basically, let's start with the introduction. Now, whenever we're talking about restrictive lung diseases, we know that this is basically when there's chronic inflammatory disease that leads to the fibrosis of the interstitium, right? So it basically decreases the compliance. Now there are some features. Initially you have to mention some features that you would see in the case that a patient has restrictive lung disease. So you'll see that they have a decreased total lung capacity, they will have decreased FVC, FEV1, and the ratio of FEV1 to FVC will increase. So the I don't know how to pronounce it, but Tiffany's index is gonna increase. So please remember that, because that's one of the we can say ways in which we can classify obstructive with restrictive. So in restrictive, there's an increase in this ratio. Okay. Now, furthermore, you also need to know the etiology. Obviously, etiology is very, very important. So we can have, most commonly, it can be either primary, such as idiopathic pulmonary fibrosis, or secondary, such as hypersensitivity pneumonitis. It can be autoimmune, such as scleroderma, sarcoidosis. It can be chemo, radiation, pneumoconiosis, or even so many infections that we know, bacterial, viral, that can also lead to these kind of restrictive lung diseases, right? So that's another thing. Now, when we're talking about what do we see, what is happening, what is the pathophysiology behind it? So the lungs or the chest wall loses its compliance, so it becomes harder to inflate. So the breathing work will increase, right? And the compliance depend normally we know that the compliance is depending on the surfactant and the elastic recoil of the lungs and the chest wall. Now this basically becomes difficult for the lungs to do when there's a restrictive lung disease, right? So but if we talk about pulmonary, the fibrosis of the interstitium, so there's more collagen, and we can say that basically makes it difficult to actually, and fibrosis that is happening, so it becomes difficult to actually expand the lungs. And we can say extra pulmonary cases can also be there. There can be extra pulmonary reasons due to these restrictive diseases, right? For example, obesity, so can lead to restriction or can make it difficult to actually inflate the lungs, right? So there is reduced compliance due to fat tissue, right? So now clinically, what are the clinical features that we can see? This is very commonly asked. So the main clinical features in restrictive disease would be dyspnea, trachypnea, cyanosis, secondary pulmonary hypertension. Now think about it. If there's hypertension, what happens? There will be cor pulmonale and chronic right-sided heart failure, right? Now the most commonly asked question, it was also asked when I was in my exam. They asked me, if a patient has a restrictive lung disease, how would they die? What would cause their death? So this is basically it. So they would develop cor pulmonale. We can say because of the hypoxia. When there's hypoxia in the lungs, right? When there's restrictive lung disease, what happens? It will eventually lead to hypoxia. What does hypoxia lead to in the lungs? Only it will lead to vasoconstriction. When there's vasoconstriction, it will lead to pulmonary hypertension. And when there's pulmonary hypertension, what happens? It'll lead to right-sided heart failure. And this is basically cor pulmonale. And obviously there would be respiratory failure as well because of the exertion. So this can basically lead to the death of the patient, right? Now, there are two major diseases that they really want you to know. Like I mentioned pneumoconiosis and like sarcoidosis and silicosis, right? That's the first thing that comes into your brain. But these are not the diseases, because there's a separate questions for pneumoconiosis, right? Why do we have this again? But what you need to remember is there are two diseases that they really want to know. Because I mentioned all of this, and then I mentioned these two diseases, and he's like, okay, I wanted these two. I wanted these two to be mentioned, right? So that is this is one of them. This is idiopathic pulmonary fibrosis. Now, in idiopathic pulmonary fibrosis, it is an idiopathic interstitial pneumonitis with fibrotizing alveolitis. Okay, so there's um we can say there is fibrosis of unknown origin. So we don't know what is causing it, or and with immune complexes deposition. Okay. Now, if we talk about now what happens is there's TGF beta, which basically leads to which plays a very important function in inducing fibrosis. Okay. And the clinical symptoms in the patient would be, for example, so this is very commonly asked, right? So they would have cough, which is non-productive. They will have progressive dyspnea and trachepnea. Okay. They will have an inspiratory crackles. Everyone remembers this, but the most important one that people actually forget is finger clubbing. So try to remember that there's finger clubbing as well. And they can also have respiratory failure and corpo morale. Now, the reasons why this occurs is very logical. So, dyspnea and trachepnea, because of the increased recoil forces, decreased compliance, it leads to trachepnea. In the case of, if you talk about inspiratory crackling or crackles, from opening of the collapsed respiratory units, right? So, this is basically leading to it. Another, we can say, symptom that these patients also face is opposing asthma. Now, this is not the normal asthma. Here, the hypersensitivity involves alveolar antigens and not actually the bronchi or bronchioles like in asthma, right? So it is different from asthma. Please remember that. This is opposing asthma, right? Okay. Now, most important one is macroscopy. In macroscopy, you can, it's written here, firm, rubbery, white areas of fibrosis in the lower lobes. Okay. It's basically within the subpleural region, and eventually it will lead to honeycombing of the lung, right? Or honeycomb lung. This is basically the final stage in which there's progressive dearrangement of the alveolar wall, and we can actually see these cystic spaces. That's why it's honeycomb, right? These are these cystic spaces that are lined by hyperplastic type 2 pneumocytes, and type 2 pneumocytes are basically the ones that are producing the surfactants, and these are basically hyperplastic, and they're making these cystic spaces. Now, normally they do not ask you the microscopy, but in idiopathic pulmonary fibrosis, the microscopy actually allows you to classify this disease into four major types. Okay, so we have the usual uh, idiopathic pulmonary fibrosis, in which we can see acute phase of um, idiopathic pulmonary fibrosis or interstitial pneumonia. Interstitial pneumonia is followed by fibroblast proliferation, which leads to collagen fibrosis plus lung dearrangement, as well as fast progression and honeycombing. So this is basically the usual, we can say, interstitial pneumonia that is present. Then we have desquamative interstitial pneumonia, in which we can see macrophages which are appearing in the alveoli. This normally has a good prognosis. Then we have lymphocytic interstitial pneumonia, in which there's extensive interstitial infiltrate of lymphocytes and plasma cells, because obviously there's inflammation, right, that is occurring. Then we have giant cell interstitial pneumonia, which is actually occurring after inhalation of fuels originated from hard metal alloys. Okay, so this is basically how we are having the development of, these are basically different types of, we can say, interstitial pneumonia occurring in this particular disease, right? So patchy fibrosis can be seen, right? So you can mention these as well. Now, another disease that is very important that they want to hear is the hypersensitivity pneumonitis. In this case, first of all, you need to remember that is a granulomatous disease. Okay. And when here we have a granulomatous reaction to inhaled organic antigens. So it can be a hypersensitivity reaction type 3 or type 4. So the etiology in this case would be either farmer's disease, which we know from microbiology, actinomycetes in mold hay. Then we have mushroom workers disease, pigeon breeders disease, bird droppings caused by bird droppings. And we have maple bark strippers disease, which is by maple bark. And then we have suberosis, which is moldy cork dust. Now, question that he asked me, because in the etiology was, you said, I said farmer's disease, I didn't mention the detail. He asked me, okay, how does it cause hypersensitivity pneumonitis, through what? Okay, so you need to remember that it is actinomycetes in mold hay. Okay, he wanted to hear mold hay as well. So make sure you remember that. Make sure you the diseases that you're mentioning, you need to know what is causing it. Don't just remember the name. Okay, if you cannot remember it, don't say it. Okay. Now, macroscopically, you can remember honeycomb lung at the final stages, and macroscopically, sorry, and microscopically, there's interstitial pneumonitis. So we can see plasma cells, lymphocytes, and macrophages within the alveolar wall. Plus, we're able to see non-caseating granulomas with giant cells and obliterating bronchiolitis and fibrosis, right? So this is what we would see in the case of a hypersensitivity pneumonitis. Now, the clinical manifestations can be of two types. Either the patient can have an acute attack or they can have a chronic, it can become a chronic disease. Very important to mention that there are two, we can say, manifestations, because in the acute attack the patient looks very different. They'll have like, it'll be like a flu-like disease, right? Flu-like manifestation. So they'll have fever, dyspnea, cough, leukocytosis, right? But in the chronic disease, because if there's a long exposure of the particular, we can say, antigen, it can basically lead to interstitial fibrosis, right? And this is basically irreversible. So what happens is they will basically develop they'll basically develop this non-caseating granulomas, which can basically become irreversible fibrosis. Now, after I mentioned these two, he asked me a question about which one is more severe or which one has bad prognosis. And it looks like a very hard question, but it's very simple. So obviously it's idiopathic pulmonary fibrosis because it's idiopathic. So you don't know why the patient's having this particular reaction. Why are they having fibrosis? You can only like exclude it after you have like done all the other tests and you check for all the other diseases. You can only exclude it by like by the end of it. So it's like you can already diagnose it by exclusion, right? So that's why it's very difficult to actually detect this disease in patients. Whereas if we talk about hypersensitivity pneumonitis, if you take a history of the patient and they said that they are a farmer, for example, you would definitely check if they have, for example, farmer's disease, right? So it has a better prognosis than idiopathic, because we would realize that a patient has an idiopathic disease later on in the when the disease has like spread more, has become even worse. So that's why it normally has like a bad prognosis. Okay, so moving on, as I said, that most of us, whenever it comes to restrictive diseases, will straight up think about pneumoconiosis, because I know that there's another question completely based on this, and we can talk a lot about this as well. But they know that, and you need to like mention the other two diseases. This, even if you mention, okay, mention it, definitely do mention it, talk about it a little bit. We have other videos on this. So there are other people who have made videos on this and they've explained everything. But if you, I can also like talk about it a little bit. Now, normally, if we talk about this pneumoconiosis, we say that it's basically when the patient has inhaled. It's a chronic inhalation of fibrogenic mineral dust. Please remember this, it's mineral dust that they're inhaling. Okay, the mechanism is that they inhale these dusts, and it basically leads to chronic inflammation, which leads to progressive massive fibrosis, leading to cor pulmonale. They can have additional complications like TB or cancer. So first of all, let's go on to coal workers disease. It's like basically carbon caused by carbon dust, and we can talk about like anthracosis. Anthracosis is very normal, present in every patient. Anthracosilicosis is a massive exposure and can lead to like black lung, for example. This is a complication. Then we can have silicosis, which is basically caused by silica, and we know that we have these quartz that are present, which are basically leading to it. So it is the most common occupational disease, and it starts from the septa to simple, forming world masses. Please remember this, world masses. It's very important because that's what it looks like. And it becomes complicated and becomes diffuse. Okay, and we see these nodular appearance, or nodules basically start to appear. Then we have, in this case, we have high risk of TB and cancer. Finally, we have asbestosis, the worst one. And we have these increased risk of lung cancer and mesothelioma. And for mesothelioma, please remember we do not have any kind of treatment. Okay, so if the patient comes with mesothelioma, very bad prognosis. And it basically irritates the pleura, causes effusion, diffuse fibrosis, pleural plaques, honeycomb appearance. And what, please remember, if we're saying asbestosis, asbestosis doesn't mean anything. What is it? What is causing asbestosis? It's the asbestos bodies, okay, which is seen in biopsy. We have these golden brown fibers covered by iron containing protein in tennis racket appearance. Now, this is microscopy. If you know it, it's good because it's very different, but then normally they don't really ask you microscopy. They're more interested in the macroscopy, which I'm sure is mentioned in detail in the other lectures about pneumoconiosis. Then we have berylliosis, which is a hypersensitivity reaction type 4. It forms non-caseating granulomas in the lung and the lymph nodes and causes fibrosis. And here also we have an increased risk of cancer. We have other diseases such as sarcoidosis. Again, a complete video on sarcoidosis is also present. And we have infections like TB, interstitial pneumonia, acute respiratory distress syndromes that can also occur, right? So one major thing that they will also ask you is the rule of opposites. So they'll ask you like, so it's not basically called the rule of opposites, but just remember that asbestosis is the only one that actually starts at the lower lobes. Okay, whereas silicosis, anthracosis, berylliosis are all starting in the upper lobes, right? So this is also another important thing that you need to remember, and that's pretty much it. Yeah, I hope it was helpful. Uh, yeah, thank you.